Hello, everyone. I am Dr. Ahmed El-Bohoty. I am a professor of obstetrics and gynecology in Ain Shams University, Cairo. And currently, I am working as a reproductive medicine consultant in Abu Dhabi. Greetings from Abu Dhabi. And I'd like to thank the scientific committee of this prestigious conference to invite me to participate with you. And I hope that we can have a nice presentation and a nice discussion after that. My topic today is a challenging topic. The title of it is Recurrent Implantation Failure, What Good We Can Do. I am trying to discuss today how does successful implantation happen, why implantation may not happen, when implantation failure is defined as recurrent implantation failure, and what good we can do for this challenging type of cases. Initially, we will go for the basic science, how successful implantation happen. We need a functional embryo, and it's supposed to be eubloid embryo. We need to have a receptive endometrium, and to have a receptive endometrium, the endometrium should be exposed to estrogen first, then to have like 6 days of progesterone after estrogen exposure. And we have successful crosstalk and dialogue between the endometrium and the embryo. And I like to mimic this crosstalk. It's like a relation between investor and the embryo. The endometrium will invest in the embryo, and this investment intends to end with a live birth. And sometimes the endometrium is so selective, and in this case, the pregnancy will not happen. And sometimes it's so receptive, and as you know, it can allow for unhealthy or pregnancy with aneuploid embryo and ends with a miscarriage. For more details how the crosstalk happens, we know there is a sequence of steps from we are now at day 6 of the embryo. We have hatching blastocyst. We will have this sequence of apposition, as you know, and then there is adhesion, and then invasion of the hatched blastocyst to the decidua. And as you know, to have a decidua, this is a hormonal effect. It will happen with pregnancy or without a pregnancy, without having an embryo even. It's just exposure of the endometrial stromal cells to progesterone will form a decidual cells. Some of the endometrium or endometrial stromal cells will not respond to the progesterone effect, and these cells will be called senescent cells. They are not receptive, they are not cooperative for the embryo. With this invasion of the embryo, according to the quality and the eubloid state of the embryo and fitness of the embryo will interact with the decidual cells. And as you know, at this time, there is recruitment of leukocytes, especially the natural killer cells, which constitutes about 70% after the pregnancy, to 70% of total leukocytes inside the endometrium. And the effect of the good embryo on the decidual cells, that it will, by releasing some chemicals like something called low molecular weight hyaluronic acid, which makes the decidual cells send specific cytokines to uterine natural killer cells to remove the senescent cells. And in this state, the pregnancy will continue. On the other hand, if the embryo is aneuploid and abnormal, the uterine natural killer cells will allow the senescent cells to continue. And in this case, the decidual cells will not be the predominant cells, and the pregnancy may end, and implantation failure will happen. Okay, this is just a short introduction by the basic science. But then why does implantation failure happen if we have an embryo and endometrium? It may be related, as we can tell, for the embryo, either for the embryo quality and to the euploid state. It can be related to the uterus and the endometrium, and we will discuss this anatomical and functional. It may also, for IVF, it can be related to embryo transfer procedures and embryology laboratory quality. And as we know, the embryo transfer procedure is the self-limiting step in IVF success. We will find that it's mostly around 30% for if the embryo is not tested. So the success of the embryo transfer is still the self-limiting step in the IVF. And actually, we don't know much about what's happening, but we will try to go and see what we know. I will exclude the embryo transfer technique and laboratory procedures from my talk, because we assume that it's a professional person who is going to do the embryo transfer, and we have a high quality lab. For human embryos, it is extraordinary, or human reproduction is extraordinary wasteful. Human doesn't have the euploid oocytes as other species. In mouse, we will find that embryos of the mouse is only 2% aneuploid, but in human, most of oocytes, more than 70% of oocytes found in the woman are aneuploid. And the pre-implantation embryos, it's like 50% of them all over the age, it's aneuploid. And if you can see that it's going to rise more and more if we are above 35, 36, or above 40, we can reach 200% at some stage, like 45 of age. So maternal age is the best predictor for aneuploid embryos. If we have euploid embryo, we can claim that we will have a fixed implantation rate after each trial. And this is what Bioretti proved in this fantastic study, which comes from his center from New Jersey, USA, when he did analysis of more than 4,400 cases, all have euploid embryos, and he calculated the success rate after each trial of the transfer. He found after the first trial, 70% of these cases were pregnant. After the second trial, who didn't get pregnant from the first trial, he did another euploid embryo transfer, single euploid embryo transfer. 60% of them got pregnant, and who didn't get pregnant after the second also have another euploid embryo transfer, and also 60% got pregnant. For sure, the selection criteria for this study are the best patients. All are young age, all have good anti-Mullerian hormone, as you can see. However, it proves for us that there is no, if you have eubloid embryo and the uterus is normal, you will have like a fixed pregnancy rate. After each trial, it's about 60%. And you will have over 3 trials, the cumulative pregnancy rate was 95%, which is fantastic. And also the live birth rate is over 92%. And this study actually makes a lot of difference for definition of recurrent implantation failure, as we will see later in my presentation. Now, regarding the quality of embryo without eubloidy, we have another proof from another study that when we transfer a good quality embryo, we will have a higher statistical difference than when we transfer poor quality embryo. And this study was done for day 3 and day 5 embryos, but this is a collective of them. Another study which include or correlate with the quality of the embryo and eubloid state. We can see that when you have a higher embryo quality like AA, you will have more eubloid embryos. And when you have a poor quality embryo like BC, you will have less eubloid embryos. However, the good thing that whatever the quality, if this embryo is eubloid, you will not have a statistical difference in the implantation rate and in live birth rate. So whatever the grade, it's as long as it's eubloid, you will have nearly the same implantation rate. So now we understood that the eubloid embryo are so important for implantation, but is it enough? For sure, no. The womb, the uterus, is very important. And not only the uterus, the age of the woman is so important, not only for the eubloid embryo, it's also important to have a successful implantation. And we have different retrospective analysis. This is from Society of Reproductive Technology, SART. You can see here that for PGTA cycles, that the success at age of 35 is 62, but at over 43, although it's also eubloid embryo, it's 48. Another analysis from also USA, from center from USA, that you can find that there is a difference, although it's all eubloid embryos, there is a difference from the age of 42 to 35. You will have a big and statistical difference. And why age can affect the endometrium receptivity? Because it's affecting the decidualization, and through different mechanisms, there is a decrease in estrogen and the progesterone receptor in the stromal cells. There is molecular changes related to age. There is some inflammation. And at the end of the day, not all the endometrial stroma will be decidua, and you will have more senescent cells which is not responding to progesterone and will end with implantation failure. Another fantastic study that related to the, or it's comparing between the gestational carrier to intended parent recipients. You will find if a couple at or the woman at age of 35 and she will get pregnant from donor's eggs, she will have less chance to be pregnant if in comparison to a gestational carrier at her age. And so the gestational carriers, whatever the age, has a better chances. But as you see, when you go higher in age, both of them will be less. But still, the gestational carrier will have higher chances of pregnancy and higher chances of live birth rate. This can tell us that for the infertile woman, she has other causes that can make her not pregnant, even if not clear, related to the womb. And also, we will see that the gestational carrier, which is totally different in immunological state than the embryo, has a successful pregnancy for that. And this is a proof that immunological aspects of recurrent miscarriage of recurrent implantation failure is not so interfering with the pregnancy. I like to have like voting for who we can consider as recurrent implantation failure. These patients, 46 years, 5 trials. Just to think, I don't, we may do like a vote at the time of the presentation. This is another patient, 38, with 3 trials of single blastocyst, embryo transfer with no post-pregnancy, and also another one, 35 years, have 2 trials of single blastocyst transfer, also no pregnancy. When I did this in a previous conference, there was controversy. Some consider all, some consider no. We will see who, according to at the end of presentation, we can answer this. And for a woman who have 3 trials with unsuccessful pregnancy, what you want to consider it as recurrent implantation failure, what you will do. Also, there is a lot of controversy. These are different options. Think about each option. And this controversy is not in this conference only. It's through all the reproductive medicine specialists, and this survey done for 1,000 clinicians and embryologists. And you can see there is no agreement for how many embryos should be transferred to consider it recurrent implantation failure. What is it tested or not, day 3 or not, and also intervention. There is a lot of controversy, and no one can firmly answer with evidence what should be done exactly for all cases of recurrent implantation failure. And when I put recurrent implantation failure at search bottom for in PubMed, I found more than till this year, more than 6,000 publications, and we don't have a clear, only we have one guideline and one good practice from ISHRI, one guideline from Canadian Fertility Society, and one ISHRI, and no clear agreement about the definition. And you can find most of studies are not so good and not so high quality studies. To define recurrent implantation failure, how can we do this with the number of transferred embryos, quality, cleavage stage, fresh, frozen, a lot of questions. And here there is more than 80 definitions you can find in the literature. The good thing now, according to the study I showed you in the beginning, that each euploid embryo has a success rate above 60%. So we can calculate a cumulative probability to get pregnant from the number of embryos transfer. If it's non-eubloid, we can calculate easier. If we don't know, we can calculate according to the age. And we can have, also, we will not have complete agreement because we can, when we will tell it's a recurrent implantation failure, some will consider 60% as a cutoff value of cumulative pregnancy rate. Some will consider 95%. And this is the difference between the ESHRE recommendation, which considers if she did more than one ET with a cumulative pregnancy rate 60%, ESHRE considered it as recurrent implantation failure. However, there was another opinion based on Lugano recurrent implantation failure workshop, which was a meeting between different specialists in reproductive medicine from USA and Europe, and they discussed the different papers, and they agreed that if we have more than 95% cumulative pregnancy rate, which means 3 eubloid embryos or adjusted number of non-tested embryos according to woman's age, we will consider it as recurrent implantation failure. And so the prevalence of recurrent implantation failure now has been changed after these new definitions. It was in the past considered as 15%. Now, according to if we consider the Lugano definition, we can consider it as actually uncommon or rare, and it's less than 5%. Now, what we can do? First, when we have a case with recurrent trials of embryo transfer without success, we need to consider, is it a real recurrent implantation failure or not? And we can put our protocol according to each center with discussion of the specialists there. This is from ESHRE. It's considering that if you have 2 or more and cumulative chance of implantation more than 60%, consider it and start to do specific investigation. If less, we need to proceed for another trial before going to investigate as recurrent implantation failure. As I told you, Lugano agreement, it was more than 95%. So what we can do, we consider this as recurrent implantation failure. Is there a rule to select embryos? And as you know, the best to do is to select by doing pre-implantation testing for aneuploidy. There is facts about PGTA. It increases pregnancy rate per embryo transfer for sure. It can help us to prioritize eubloid embryo transfer, but it does not increase cumulative pregnancy rate. And we have also this study that showed that if we have 3 or more eubloid embryo transfer for a patient, and we have in comparison non-conventional IVF without, we have 3 embryos without testing, we will have at the end of the day non-statistical difference, and even for the conventional IVF without PGTA, the cumulative pregnancy rate was higher than PGTA group, but it's not statistically different. So this study showed that it will not make a difference, but as you know, PGTA can add more cost, more invasion to the embryos, whatever the disadvantage. But for the group of recurrent implantation failure, for sure we can consider it as a choice, especially if you have a big number of embryos. Does selection by time lapse will help? No, it will not help, and this is approved from a study for you can find that the time lapse group showed non-statistical difference of pregnancy, of ongoing pregnancy. So regarding the uterus and endometrium, as you know, there is anatomical causes, and for sure you need to treat these anatomical causes, especially does have a causal relationship like hydrosalpinx. You need to close or to remove the, if you have submucous myoma, intrauterine adhesion, you need to treat this. There is no causal relationship for some causes. You may consider treatment if you have repeated failures, like have intramural myoma or adenomyosis or septum. And also we can suppose some functional abnormality, and this I will go to discuss it into some details, especially what can make endometrium not receptive. I will start with this cohort study that compare between limited number of people, say 86 women with recurrent implantation failure with 37 without a recurrent implantation failure. And we can find that one of the things that vitamin D was lower in the recurrent implantation failure, but we cannot take this as a big evidence, but we can give vitamin D for who are deficient, no problem. We can find that chronic endometritis more common with recurrent implantation failure. But regarding the ERA test and estradiol, prolactin, all other hormones, antiphospholipid were the same in both groups. Okay, I will start with the protocol of preparation for recurrent or for does it will make a difference? We don't have evidence that any protocol is better, fresh or HRT or whatever, but we need to consider some aspects related to the progesterone level in two stages. One of them is the late follicular stage and the other at the mid-luteal stage. And I will begin with one study from Egypt, which is related to, which proves that for recurrent implantation failure people, we have better results with freeze-all. Then you can find the implantation rate is higher for the freeze-all group in comparison to fresh embryo transfer. And this may be related to ovarian stimulation as it can advance the endometrium. And we have a lot of evidence that the level, if it's at the day of trigger above 1.5 nanogram per milli, it's better to go for freeze-all. The second important level of progesterone is the mid-luteal phase, and this is very important, especially when we are going to prepare for frozen embryo transfer. And we can find from this study that make a cutoff value of 8.8 nanogram milli, that if the level is above this, the pregnancy rate will be higher than if it's below this. And we find that according to this study, that 30% of patients receiving vaginal progesterone in the usual dose will have less optimum progesterone level. And we can find this especially when we do this analysis for the BGTA group. We will find the pregnancy rate, the mean pregnancy rate was 34% in comparison with a higher progesterone with 54%. So improvement of progesterone, mid-luteal progesterone, can help the pregnancy rate for artificial cycles. And also if we have another evidence for the natural cycle for FET, we will find that also there is this, according to this study, the level was 10 nanogram per milli. If it's below this level, we'll have at least 15% difference in live birth rate. So it's important to measure and to supply progesterone. Or the other option is to give intramuscular progesterone. This study from USA showed that group who take intramuscular progesterone or combination of intramuscular and the vaginal progesterone is better than the vaginal progesterone alone in clinical pregnancy rate, and also the pregnancy loss was less and the live birth was higher. We have also weak evidence related to the long protocol for idiopathic repeated implantation failure, that it may improve also the pregnancy rate in comparison to other protocols. Other factor to consider is the endometrial thickness. And according to this big analysis of like 100,000 embryo transfers, we find for the best cutoff value for endometrial thickness for fresh should be above 8, and for frozen it should be above 7 millimeter. However, sometimes we may find challenging cases with thin endometrium, and according to ESHRE recommendation, we need to ensure the sufficient exposure to estradiol. We can change the protocol. We can do hysteroscopy to exclude adhesions. And another evidence from some studies that if you do long protocol for preparation, you may have more endometrial thickness, as it can reduce this long desensitization, will make the endometrium more sensitive to estrogen. So you will have, with less dose of estrogen, more endometrium, more thickness, and this can help to have more pregnancy according to this given stats. Now, regarding the ERA, endometrial receptivity assay, this test was marketed heavily and used before we have a proof of evidence, and theoretically it's fantastic. However, when we see after now about 10 years of use, there is no supporting evidence, and we can find this study that showed that ERA test didn't improve the clinical pregnancy rate or ongoing pregnancy rate, and also this meta-analysis of multiple studies also showed it is the same as without testing. There is now a trial to have a lot of research about markers that can tell this cycle is receptive or not receptive. Another issue is also to be discussed is chronic endometritis. I will go so rapidly as for the time. It's difficult to diagnose. It's no clear symptoms, and we give usually empirical treatment, but there is some evidence. That's why the ESHRE recommended if it should be assessment for chronic endometritis can be considered, and if it's diagnosed, it can have treatment. And this is a weak evidence based on observational studies for that cure of chronic endometritis for recurrent implantation failure makes more pregnancy. Other topic also the dysbiosis, and dysbiosis actually is now is era in the medicine, but however also there is no clear evidence that the endometrial microbiota, if disturbed, it will cause recurrent implantation failure. We have these studies that showed with recurrent implantation failure there is no problem for the endometrial microbiota. Immunological tests, a lot of studies, a lot of tests, a lot of BRB, cortisone, a lot of things, but we don't have a clear randomized controlled trial to give any improvement for efficacy. And most of interventions used as empirical, so it is not recommended by any guidelines or by me to be used, in addition to the cost and of it. Hysteroscopy, it's proven for by this trophy multicentric randomized control trial. It's not helpful for recurrent implantation failure. Also, scratching, it's also proven by this multicentric randomized trial by a new published in New Journal of Medicine, that it's not improving the pregnancy. So we can tell the prognosis that after 2 failed trials of eubloid embryo transfer, the chance is still 60%. So now we are going to conclude this presentation. Recurrent implantation failure has been over-evaluated, over-diagnosed, and over-treated without sufficient critical evaluation of the presumed condition. Unfortunately, no good evidence to support the management of real cases of recurrent implantation failure. So we need to improve the quality of research, to have good research to try to solve this elusive problem. My recommendations for the clinicians, when they are facing cases with recurrent implantation failure, they should do proper explanation of the couple about the prognosis and being honest about the evidence of any intervention. And they should have individualized evaluation and management with no hurry to offer patients unproven diagnostics and potentially harmful treatments. Repeated trials of embryo transfer can be the only needed action for many couples. BGTA may shorten the time to pregnancy if we have many embryos. It changes the protocol of preparation of embryo transfer with proper monitoring of endometrial thickness and the progesterone level may help. Addition of more progesterone can add more success for who has lower luteal progesterone. For when we have aeroplane falls, we have black box to analyze why this happens. Unfortunately, when embryos falls, we cannot have this black box. We actually put the embryos in a black box. We don't know what is happening after that. There are now systems to study how with the implantation and how can we make variables for to mimic what's happening inside our body by doing the plastoids and organoids, hoping this can find a solution for this difficult condition. And I will update you also with recent presentation by Carl Simon I attended in France this month in Paris, under this title, New Embryo Transfer Techniques, Don't Throw Away Your Embryos into a Black Box. And Carl Simon offered, or he is doing a new way of transfer to avoid transfer in a black box. He or inside the endometrial cavity, he is putting embryo inside the endometrial stroma directly. And he will start this on humans, I think by March 2024. So hoping to also to be successful. However, after his presentation, there was a lot of arguments. Some agree, some disagree. I think it's an innovative process. Let's see what will happen. This is my references, and thank you all for your attention. And I am ready to have any questions and discussions. Thank you.